Welcome to MetroSTL. I'm your host, Charles JACO. Today, we are pleased to be joined by Dr. Ziyad Al-Aly. He is an assistant professor of medicine at the Washington University School of Medicine. And more to our purposes, is the principal author of a new study published in the journal Nature that shows that COVID patients, even months after having had COVID, are likely to get some very, very serious consequences. And we're glad to talk to him about it today. Doctor, thank you very much for being with us. We appreciate your time.
Well, thank you for having me.
So tell me, what was the biggest surprise to you in this study? I mean, you have looked at people who had COVID. What did you find? And was there any shock there in any of it to you?
So we knew all along that some people with COVID don't fully recover, and months after COVID have fatigue or some lingering shortness of breath and cough. But what we did is we did a comprehensive assessment of all the possible diagnoses or possible diseases that people with COVID are manifesting with. And we found that people with COVID, long after the initial infection was supposed to have resolved, they're manifesting with increased risk of diabetes, heart disease, obesity, of course, lung problems, kidney disease, and also mental health disorders. When you put everything together, we put all of this together, that was a shocking moment. That long COVID truly exists. Long COVID is really serious. It's not only fatigue or shortness of breath or cough. There is really clearly a higher risk of new onset diabetes, new onset heart failure, new onset kidney disease, and several other manifestations that may not resolve with time. These are chronic diseases that are likely to last a lifetime.
Now, long COVID, of course, is the term of art we use for people who just can't seem to get over the virus. I understand there were tens of thousands of people you studied going over medical records from the VA, 80-some thousand, I believe. What percentage of people who had COVID are still experiencing moderate to severe effects months later? Is it 20%, 10%?
This is a very, very interesting question. So the estimate on average is about 8 to 10%. And while that's maybe, a little bit, people may think like this is really a small number, just given the enormity of the number of people who have COVID in the United States, that's more than 31 million people, 8 to 10% will likely represent a substantial, burden of disease and something that the healthcare system should really start to quickly adapt to and cope with to deliver proper care to these patients. So overall, the estimate is about 8 to 10%.
8 to 10% of 30 million people, that would be, over 20 million people, maybe more. So tell me, what are the most common effects? You mentioned across a broad range of diseases and internal organs. Which is the first among equals? In other words, what was the most common long-term effect you saw?
We still see a lot of fatigue and respiratory symptoms, including lingering shortness of breath and lingering cough. Those really always on top, respiratory symptoms and fatigue. But in addition to that, we see new onset heart problems, that's heart disease, kidney disease, diabetes, and also mental health disorders. And that was actually also a bit alarming. There is an increased risk of depression, anxiety, and substance use disorder. And we think that that's really, people should be aware of this, and doctors and health systems should be screening for this and addressing it early on, or quote unquote nipping it in the bud, so before it balloons to a much larger crisis down the road with increased suicide and other things. So it's sufficiently alarming to really develop strategies to deal with it on the front end and nip it in the bud, so to speak, so it doesn't really balloon into a larger crisis down the road.
People might tend to be a little confused because they think of COVID as primarily a respiratory disorder, but you're talking about renal diseases, you're talking about cardiac diseases, you're obviously talking about respiratory diseases, you're talking about neurological problems. Do we have the slightest idea how the SARS-CoV-2 virus is able to create bad effects in so many different organs of the body?
This is a wonderful question. So there are hypotheses. There are no confirmed studies yet into like how does the virus go on to attack the brain and the heart and the lungs and the kidneys and the liver and multiple other systems. How can one virus, does so much, like do so much damage to a lot of organs? So the leading hypothesis is that the way the virus attaches to the cell, it attaches to the cell via a receptor that is nearly present on on a lot of cells in the body, including cells in the brain, in the lung, in the heart, in the liver, and the kidney. And that's its sort of mode of entry and mode of attacking those organs. That's a leading hypothesis that has not been firmly confirmed yet, but that's what we think most likely is happening. And that explains why one virus could be attacking so many organs.
Was there anything besides being patients at the Veterans Administration, which was the database you used, that the people who suffered the long COVID effects had in common?
There was no unifying thing. We saw it all across the board. We saw it in young people, we saw it in old people, we saw it in males and females, we saw it in people who really are healthy at baseline. Those people are like young and healthy at baseline and strong and still had a risk of long COVID. And we saw it in older adults. We saw it in people who really, so we saw it all over the place. And that's really sort of almost like an indiscriminate, that there was no one peculiar group that we felt that those are really the most at risk. Now, I have to say this, that the risk is significant and small, but not trivial in people whose disease at baseline was mild, it did not need hospitalization. Was higher in people who really required hospitalization for acute COVID, and highest in the people who required ICU care. So it seems that the severity of infection at baseline, the severity of COVID, people really had more severe infection at baseline that made them or had them require hospitalization, and ICU care had the highest burden of long COVID.
But what is a physician to do? Let's say someone presents and they obviously have COVID-19. What can a physician do? What can the patient do to prevent these effects further down the road? Because your first order of business is to try to stay alive if you have a severe case of this stuff. But what can be done to ameliorate these effects down the line, or can anything be done?
That's a wonderful question. So for those people who haven't had COVID, if they haven't taken the vaccine, the best way to prevent long COVID or to prevent COVID is to get vaccinated. So I hope that answer is clear. So for people who really are not vaccinated yet, the best way to prevent them from having COVID is to get vaccinated. For the people who have COVID and are at risk of long COVID, we think some of the manifestations that we have reported are kind of silent diseases, like early onset diabetes or kidney disease. So both physicians and patients need to be vigilant and seek preventive care at the earliest opportunity and get checked for all these manifestations to make sure that if they have them, they're aware of them from the get-go at the beginning when they're relatively mild, and those are addressed early on before they go on to become much more severe manifestations down the road.
So will these symptoms actually present early on? You said some of these people were healthy, and I'm assuming that means people who had no history of cardiac problems developed cardiac problems, people who had no history of renal problems or neurological problems or respiratory problems developed those. Do they present early enough on so a physician can take action immediately and perform triage and minimize the damage?
So some of the manifestations, some of the sequelae of long COVID are like having blood clots. I mean, those are going to become evident. If somebody has a blood clot and it travels to their lung, they're going to experience shortness of breath, et cetera, et cetera. So some of the manifestations will present with clinical symptoms and become evident. Some of them, as we discussed, are silent diseases like diabetes in early stages. Somebody can have diabetes but not know it, or somebody can have kidney disease and not know it, or somebody can have some liver damage but not know it. For those manifestations, we think if people had COVID, continuing or seeing a primary care physician for a health check, and the primary care physician should be aware of all these conditions and make sure that they screen for them to identify them early on.
Now, does this mean that work through this with me? Does this mean that people who have COVID may have these conditions pre-existing, but they're dormant? Or does COVID just create them out of whole cloth and they had a perfectly healthy kidney or heart before, and now it's damaged specifically before COVID, or is it a combination of the two?
So no, it's the latter. So our design, our study looked at the new manifestations. So the people did not have kidney disease at baseline or did not have it prior to getting COVID. They got COVID and they got kidney disease after COVID. And then when we looked at diabetes, these people did not have diabetes before COVID. They got COVID, and all of a sudden after COVID, that provoked an inflammatory response and then decreased insulin, and subsequently these people had diabetes. So these are all new manifestations that happened after having COVID.
Now, you crunch the numbers from the Veterans Administration database. There are going to be some who argue that that might have been flawed simply because in a lot of cases, patients at the VA tend to present sicker, or they may have a less healthy population to deal with than the overall medical system. Is there anything to that, or are you confident that these numbers may apply to the population as a whole?
No, we think broadly these numbers may apply to the population. I think the one concern about, we have to always interpret things with their own, and objectively. I think one of the concerns about the VA is the majority of the VA population is actually male. So that's a valid concern. That is certainly a valid concern. However, our sample was sufficiently large. We had more than 87,000 people, and that included more than 8,800 women or females in our study. So we think those and we took care to make sure that we include in our statistical analyses and our methodologies all sort of controls to ensure that our analysis is robust. So we feel confident about the results, and that provide us with a glimpse of what long COVID looks like and what are the manifestations that are, or the range of manifestations that could be seen in long COVID. I also have to say that no one person will have all of these manifestations that we described. No one person will have all of this, have heart disease and lung disease and kidney disease and liver disease. But what we're saying is that long COVID can manifest in different organ systems, and some people can result in lung problems or shortness of breath and cough, and some other people can present in increased or new onset diabetes or heart problems, and some other people it may present as kidney problems. No one person will have all of those manifestations.
Final question for you, doctor. What would you have to say to people who get their medical advice apparently mainly from Facebook, who will say things like, well, I'm not going to get a vaccine, or, well, this only affects 99.9% of people who get this recover and it's no big deal. That stuff is still out there. What does this study on people having these serious effects months later tell you about those attitudes? Because to me, it would seem to make them even more dangerous, and that you're not just denying the existence of a disease that may make you sick or kill you over the short term. You're denying the existence of almost a syndrome that could make you incredibly ill for a very long period of time. And what would you say to those folks?
Certainly, long COVID is a syndrome, and we think that COVID is very serious disease to start with, and it certainly in some instances can be associated with long-term sequelae or long-term consequences in the terms of long COVID. Long COVID itself is serious, and as we've shown in our studies, it also is associated with higher risk of death and needing hospitalization and death. So our advice to people is that if they haven't gotten the vaccine yet, the best way to avoid COVID and avoid long COVID, which is really a serious deal, it's a serious problem. The best way to avoid this is to get vaccinated. So that's really, I really hope that sort of encourages some people to get vaccinated as soon as possible.
Dr. Ziyad Al-Aly, Assistant Professor of Medicine at the Washington University Medical School and principal author of a new study showing that long COVID is very real, and perhaps 10% of people who get COVID. Doctor, it's been a pleasure. Thank you very much for joining us.
Thank you very much for having me.